have a mic. Piece of paper out. All right, good morning. We'll get started here. Richie's not feeling that good, so he's off today. So I'm going to do the honors of the introduction. So we're very happy to have Dr. Clarence Braddock here today. And so as you all know, we kind of align with St. Vincent's when we have visiting professors in, and he was invited as part of the Donald Olson Memorial Lecture and spoke at St. Vincent's yesterday, and we're pretty happy we were able to arrange a schedule and have him come here today. So he earned his undergraduate degree at Stanford and MD at the University of Chicago, did his residency in the U.S. Navy, and received a master's in public health in healthcare ethics from the University of Washington. He spent time at UCSF, and then the majority of his career was at Stanford, where he was a professor of medicine and associate dean for undergraduate and graduate medical education at Stanford University. He also was the director of their medical education research and innovation, directing the Rathman Family Foundation Medical Education Research Fellowship. He's very accomplished in a wide variety of areas, but looking at his CV, clearly ethics, doctor-patient communication, medical education, and the alignment or interaction of those have been his particular interests. He is, as you would expect, well-published, over 60-plus peer-reviewed publications, numerous chapters, and invited lectureships. He currently is a board-certified internist who still practices on the inpatient units in general medicine and is the vice dean for education in the David Geffen School of Medicine at the University of UCLA. He's also the chairman of the board of directors of the American Board of Internal Medicine. So if you have any questions or comments about the MOC program, I'm sure he would be glad to deal with those. And with that, thank you very much, and we'll get started.
Thank you. Thank you so much. Well, good morning. It's a great privilege to be here with you this morning. It's always great to come back to the Northwest. I spent 10 years in Seattle and have a lot of colleagues and good friends here in Portland, so it's been a delight to be back here. Today I'm going to talk about shared decision-making, and I chose this topic in large part because as I learned about Dr. Olson from the folks at St. Vincent, as someone who is dedicated to the doctor-patient relationship, it seemed like a good topic, and also because shared decision-making and patient engagement is very much in the vernacular in hospitals and health systems and patient care delivery these days. So what I hope to do over the next several minutes, and I've scheduled this so we should have plenty of time for Q&A at the end, is to review a few things specifically to enable us to have a sound understanding of what we mean by patient engagement and shared decision-making, to discuss the rationale of why those have become so important and so prominent in clinical practice, and then to share with you some promising and what I think are very practical approaches that are emerging around the country to promoting more shared decision-making and better patient engagement. So I'll divide the talk in really three parts, the what, the why, and the how. So let's start with the what. So first I'll begin with defining these terms so we make sure we know what we're talking about together. This is a definition of patient engagement, and largely patient engagement has been an evolution from the concept of patient-centered care, where if you imagine that as being to say, we're not going to just do things to patients, we're going to do things for patients. And the shift is to patient engagement, where it's saying we're going to do things with patients. So this definition from Angela Coulter, an prominent author in this area, talks about this notion of reciprocal tasks, or people working together to support active patient and public involvement in health and healthcare, a very broad definition. This next chart, which comes from a very important paper in Health Affairs a couple of years ago, lays this out across the domains of direct patient care, organizational design and governance, and policymaking. So for example, many healthcare systems, probably Providence included, have moved from simply getting consultation from patients through surveys and about their experience to actually forming patient advisory councils and increasingly having patients in sort of co-leadership roles of important oversight committees for the clinical enterprise. In the policy world, we think about the Patient-Centered Outcomes Research Institute, PCORI, has really tried to drive the initiative of having patients and the views of patients more prominently integrated into things from research question formation, study design. So again, you're seeing this shift from consultation to real engagement and leadership. For today, we'll focus on the direct care realm and the shift from merely providing patients with information and asking about their preferences to truly trying to engage in a shared way in clinical decision making, which is the marriage of the patient's preferences and values with our knowledge and clinical judgment. Now, shared decision making as a term probably originated in the early 80s from a president's commission. There are a number of presidential bioethics commissions, as some may recall, in the late 70s, taking on a large number of important problems in medicine, one of which was informed consent. So the President's Commission report on informed consent suggested that the concept of informed consent could be traced to two fundamental principles, fundamental values, ethical values in medicine. Personal well-being, the idea that we're trying to promote the patient's well-being, and also at the same time respect the right to self-determination. And they suggested that rather than thinking of consent as the recitation of a form, right, a consent form, to think of it as a process of shared decision-making based on mutual respect and participation. The clinician brings to the table his or her expertise and judgment. The patient brings to the table their values and preferences. So this is really the beginning of trying to move from the informed consent era, which, as we all know, was largely dictated by the courts, to shared decision-making, which is really attempting to sort of situate the concept of consent in the doctor-patient relationship. There are different definitions of what are the parts, if you will, the anatomy of shared decision-making. This is one that I published a few years ago. The components include things like understanding the patient's desired role. We'll talk more about that in a bit. Certain elements of what's being decided, the alternatives, pros and cons, the uncertainties related to that, the impact on the patient's life, making sure the patient has adequate understanding. Again, they don't have to know everything, but adequate, sort of functional understanding to be able to be an active participant, giving them the opportunity to solicit input from trusted others, partners, spouse, friends, maybe their primary care physician, and finally finding out what their preferences are from a range of recommendations that we believe with our clinical judgment make sense for them. Some have attempted to sort of distill these elements down to more pragmatic models. One that's rather popular is the so-called ask, tell, ask. This actually comes from a paper in which these authors were using that model to look at prostate cancer screening. So it starts with asking the patient about their baseline knowledge and their thoughts about prostate cancer screening. Have you thought about whether you want to be screened for prostate cancer? It's an important way to find out what the gentleman knows about prostate cancer screening. And as you know, I'm sure you can reflect on your own clinical experience. People walk in the door with lots of different baseline knowledge and preconceived notions. The tell is really largely to provide information, to suggest ways in which other men have dealt with the choice, etc. And then finally, the second ask is to really try to elicit from the patient their views on how they think they'd like to proceed. So this is another model. For the purpose of today, I'm going to actually explore this in more depth and focus on really three components. How do we activate the patient? And what I mean by that, we'll talk about it in more depth, but basically is to say lots of patients come to the clinical encounter not really sure what their role is in making decisions. And so we need to kind of make sure and prepare them in ways that are important. Then, of course, they need to be informed. And then we need to be prepared in a patient-centered way to engage with them and try and reach a decision. Well, let's go on to the why. And in this, I'll talk a little bit about the ethical foundation, some empirical evidence that's starting to bolster the argument for shared decision-making, and the more recent developments in the health policy realm that really are driving shared decision-making much more significantly in practice. So here are three gentlemen. Bonus points for anyone who can name all three. That's all right, it's a trick question. This is Immanuel Kant. This is Jeremy Bentham, two last era philosophers. and this is Jack Wenberg of the Dartmouth Atlas. And you'll see why I'm highlighting these three gentlemen. So the ethical foundations we'll talk about, the empirical evidence, and then the policy rationale. Let's start with the ethical foundation. So Immanuel Kant, for those of you who might remember your college philosophy course, something about the categorical imperative, was the founder of a branch of applied philosophy known as deontology, the notion that if you're trying to figure out what's the right thing to do, you should appeal to some fundamental moral or ethical principles. And so basically there's a set of rationale for shared decision-making that essentially says it's the right thing to do. Largely this comes from the growth of modern bioethics, late 60s, early 70s, and really trying to codify that into a set of ethical principles that we all learn in medical school and we largely try to use to guide our clinical practice. This notion of beneficence, trying to promote well-being, and respect for patient autonomy being the two pillars that really underlie the reasons for doing, the ethical reasons for doing shared decision-making. Others have incorporated shared decision-making into other models of sort of principles to guide patient care. Patient-centered care, which really arose in the 90s and into 2000s as a guiding set of principles to promote better relationships with patients, had these 6 sort of general precepts, at least in one model, one of which is finding common ground, the notion of, again, a guiding principle to say that's the right thing to do, to try to explore common ground with patients with regard to clinical decision-making. Even in the IOM report, the early report on quality, the IOM began to explore all the broader aspects of quality and made the point that quality means providing certainly appropriate services in a technically competent manner, but also meant good communication, shared decision-making, and cultural sensitivity. So these kinds of frameworks help to underlie the foundation for why shared decision-making from an ethical standpoint is the right thing to do. So Jeremy Bentham, also member from college philosophy, utilitarianism. So again, this is the branch of philosophy that says that we're trying to figure out what the right thing to do is. We should look at the consequences, the outcomes. And largely there's a body of evidence that's really been building for 20 plus years that shows that all the ways in which involving patients in decision-making can improve outcomes. This argument really begins with a set of studies looking at what patients themselves say about their desire to be involved in decision-making. And largely they show that from about 2/3 to 3/4 of patients in general, again there's always exceptions, prefer shared decision-making. And this study is compared to making decision-making, doing decisions completely themselves or completely leaving it to their physician. In this study, the authors found that almost all people wanted some information and choices, even though they were about half split upon whether doing so they would make the final decision or leave it to their physician. And again, this finding's been pretty durable for at least 20 plus years, and I think is an important, again, foundation for the empirical argument. Now, you might be sitting there thinking, well, it's not 100%, and that is true. Maybe we can talk about that in the Q&A. There certainly are reasons where, times where patients, either because of the acuity of illness, that's a very common scenario, or potentially cultural barriers or cultural beliefs about the appropriate role they want to play, and we can talk more about that. But the bottom line is that the vast majority of patients do want some role in decision-making. Now, on top of that, there's been a growing number of studies showing that when you involve patients in decision-making, you actually can achieve better clinical outcomes. I'll say it again. When you involve patients in decision-making, it can promote better clinical outcomes. In areas like asthma, through better adherence, outcomes in depression, ischemic heart disease, mental disorders, and even some older studies with blood sugar control and quality of life. Probably the biggest area of research has been research around decision aids. How many people here are familiar with decision aids, just out of curiosity? So, okay, a fair number. Decision aids in a nutshell are products. They're patient-based tools that are designed to help patients get prepared to be active and informed participants in decision-making. They typically include evidence-based information about treatment options, provide some relatively balanced, value-neutral presentations of advantages and disadvantages of the choices, and tools to help them clarify values and preferences. So over the past 25 years or so, decision aids have grown in number and quality to be a quite substantial presence now in the healthcare landscape. In fact, this chart shows the number of randomized trials studying the impact of decision aids when implemented in practice on patient care outcomes. And this comes from the Cochrane collaboration, and as you can see, went from about 17 in 1999 to, at their last report, 115 randomized controlled trials. Some of my colleagues who do work in this area like to say that if you had a new treatment, a procedure or a device that had 115 randomized controlled trials showing its effectiveness, it would probably be pretty much in mainstream practice. So it's actually a very impressive body of work. What do these 115 randomized controlled trials show? Well, they show improvements in the quality of decision-making, higher knowledge, more accurate perception of risk, a better match between patients' values and their choices, reduced decisional conflict, helping undecided people to decide, making patients less passive in decision-making, and improving communication. But also shows the potential to reduce overuse. There are certain areas, particularly for in settings where there may be a risk of overuse, where decision aids have been able to show reductions in surgery, prostate cancer screening, and hormone replacement therapy. And these are just a few of the findings. Certainly, if you're interested, I would point you to the Cochrane collaboration systematic review of this in 2014. It's fascinating to look at the vast array of decision aids. So what about the policy rationale? So as I said, this is Jack Winberg, a very well-renowned health economist who early in his career at Dartmouth got very interested in practice variation. So he was really the creator of the so-called Dartmouth Atlas. And if you're not familiar with the Dartmouth Atlas, it kind of looks like this. And basically what they did is they took Medicare claims data and analyzed it to look at the rates of certain interventions and procedures and such across different regions, and found significant variation in the rates of procedures, whether it's cesarean sections or surgery for low back pain, et cetera, et cetera. And they began to ask the question, why so much variation? And in the model that they created, they came up with sort of three categories of the drivers of this variation. One was the notion that in some areas there was quicker or slower uptake of evidence-based recommendations about what was effective. So sometimes variation is because one area, the community hadn't really been taking up new evolution or changes in practice driven by evidence-based recommendations. There also is a notion that in some cases utilization and variation could be driven by supply. Probably the best example of that is imaging. If you go to a small community that doesn't have an MRI scanner, you put in one MRI, utilization goes up. You put in another MRI unit, utilization goes up. The more MRI units you put in, the more utilization goes up. So there are certain kinds of procedures that are very sensitive to the supply. The final category is what they call preference-sensitive care. And this is the notion that some procedures, some utilization is driven by the practice style of the physician and the input of the patient. And hip and knee replacement, back surgery, they're great examples, C-sections, great examples of some physicians train in an environment or an institution that does a lot of C-sections. Others go train in an institution that doesn't do as many C-sections, tries to not do C-sections. And depending on your training and your practice environment and the community in which you practice can drive that utilization. And similarly, there may be situations in which the patient's values and preferences, this was their hypothesis, if you took into account patients' values and preferences and let them think about, particularly for interventions where the evidence is not completely clear about one being better than the other, surgery for back pain, that the preferences could potentially eliminate some of the undesirable variation in a very positive way. So that's the gist of the policy argument. Now, over the years, there's been an increasing number of studies looking at whether this is in fact true. One very important and recent one was done at Group Health, and published in 2012. They took these decision aids for hip and knee surgery, and when patients were being referred by their primary care doctor to the orthopedic surgeon, they were given a decision aid, a booklet and a DVD to review at home, to give them information about their choices, about the advantages and disadvantages, likelihood of success, et cetera, et cetera. And when they came to the orthopedic surgeon, they were more prepared to engage in shared decision making. And what they found was that using that approach with all their referrals, they saw a reduction in rates of hip and knee surgery, about a 26% reduction, relative reduction in hip, and a 38 relative risk reduction in rates of surgery. And this went on to actually translate to 6 months out to significant reductions in cost. Now, this isn't to say that shared decision making is about driving down costs, but it did demonstrate the ability to change utilization of preference-sensitive decisions through use of shared decision making. Another study done by his son David Wenberg, looking at a health system level, they actually did a randomized controlled trial of shared decision making across 170,000 patients in this health system, so a pretty large study. In this case, they provided decision aids for key medical decisions. They employed health coaches to help patients with self-care and behavior change. And what they found was they were able, through this intervention, to drive down total cost by $8 per member. Now, $8 doesn't sound like a lot, just barely gets you a latte these days. But you multiply it by 170,000, you can see this, you're talking about some significant financial impact for this health plan. Largely, the reductions came from reducing inpatient stays, both inpatient stays and outpatient surgery, and a little bit of outpatient visits. A slight increase in pharmacy costs, which kind of makes sense if people are opting for more medical management versus surgical. But again, a very interesting demonstration of this notion that shared decision-making could reduce undesirable variation in preference-sensitive decisions. So this kind of data started to get the attention of policymakers, particularly at the writing of the Affordable Care Act. So the Affordable Care Act actually has several provisions, and I'll show you two, that took that kind of data and tried to drive shared decision-making as one way of improving the quality and value of care in the United States. So this provision called to produce more patient decision aids, to set quality standards, and to do these resource centers. This hasn't gone very far, although probably the one example of how this has moved forward is in Washington State. And many of you know that Washington State did pass legislation to incentivize use of decision aids. The healthcare authority is creating standards for decision aids so that we'll be able to meet a certain standard in terms of evidence-based information, et cetera. And so it's been very interesting to watch that and see if that may occur in other areas. Similarly, the CMS Innovation Center has funding to drive new approaches to informed decision-making through the CMS innovation activities. So we'll be watching this closely over the coming years, particularly to see how things evolve in Washington State. There are a number of states besides Washington that have legislated shared decision-making, typically in one or two ways. One is to go about setting standards for what qualifies as high-quality decision aids. But importantly, one approach that's being taken is to legislate liability protections for physicians who engage in shared decision-making and subsequently have a malpractice suit. So, for example, there are caps on, in many of these legislative efforts, there are caps on liability for harm if there's evidence that the physician has employed a certified decision aid in the discussion with that patient leading to that intervention. So that's happened in several states. You can see that us in California and here in Oregon, there's legislation pending. At least at the last I checked, it hasn't been passed. I could be wrong, but both of our states are, I think, poised to try to do something important in this area. The other thing that happened I thought was interesting in Oregon, I thought I'd share with you, is a study that was done with the rural practice-based research network, trying to look at the implementation of shared decision-making in smaller community-based practices. And so they identified these 6 practices in and around the state. The Foundation for Informed Medical Decision-Making provided coaching to the staff, to the physicians, and provided the decision aids, and they rolled those out. These are some of the practice sites. I don't know where any of these are, but maybe you know folks there. I thought I'd at least share the pictures. They might look familiar. What they looked at, first of all, was asking patients. They really wanted to see whether the decision aids would have the same value in these community-based smaller practice sites. And so this compares the Oregon Rural Practice-Based Research Network with other sites in terms of the value. So patients were very or extremely likely, pretty comparable to other sites, so very positive uptake by patients of the value of these. And similarly, across a set of different conditions that they used shared decision aids for. Again, this shows a percent that were very or extremely helpful in guiding decision making. So pretty comparable results. Again, pretty positive uptake by patients. So as you can see, this sort of notion of patients preferring shared decision making increasingly being shown to help improve patient outcomes, and this emerging policy rationale is really the reason why today shared decision-making, patient engagement is so much in the vernacular. So in the balance of time, I'm going to share with you what I see are some promising and I think very practical approaches to how to actually try to promote this more extensively in our clinical practice. And I'll return to this model to walk you through a few examples of some of those kinds of approaches. First, we'll talk about the activated patient, then how to inform the patient, and how we can sort of provide ourselves and our peers with tools to more actively engage the activated and informed patient. So let's talk about patient activation for a moment. This is the notion that patients oftentimes either because they're intimidated by the physician or they just have been kind of accustomed to a more passive role may enter into the medical encounter not expecting or not really knowing what their role is. And so the notion of patient activation is to take people who don't know what their role is, to build some confidence and actually have them be engaged in a way in partnership with the physician. One very simple demonstration of that is this intervention, which occurs in the waiting room. The idea here is that you have a health coach who approaches patients in the waiting room. This intervention takes about 10 minutes and starts to prepare them for the visit, the goal of which is to have them have a short list of questions relevant to their concern, ready for when they meet with the physician. They talk first about decisions made in everyday life. Should I get non-fat milk or low-fat milk? They talk about what is a decision and talk about how asking questions can help enhance their role in decision making. They then talk about what the focus of the visit might be. What might be some relevant questions today? They brainstorm what those questions might be. Try to help them focus, to have them be very concise and on-point questions. And then identify the most important questions so you don't get the Dead Sea Scroll of questions. You get a more finite list. And in fact, that's been a very positive approach to trying to help activate patients for the visit. Another model that's out there is not having patients come up with their own questions, but this comes from Australia. This is where basically they showed patients a short video encouraging them to ask these 3 questions. Just ask these 3 questions. The questions are, doctor, what are my options? One option is always to wait and watch. So whether it's your cholesterol is too high or your blood pressure is too high or this and that, well, doctor, what are my options after you say I'm going to prescribe X? What are the possible benefits and harms of those options? And how likely are each of these benefits or harms to happen to me? This is found to be very effective in this environment because people, is maybe a little bit more efficient than the 10-minute waiting room intervention. That's an interesting idea. They were able to show that a phenomenal number of people actually, after watching this short video, actually did ask these questions in the subsequent encounter. So this ask model, ask 3 questions. It's another interesting approach to promoting patient activation. Some of these approaches have been able to show that patients develop more confidence and ask more questions. They develop more these so-called participatory behaviors, asking questions, making expressions of concern. It actually kind of moves them from a very passive role to a more engaged role. Another way to promote patient activation is just to try to understand, if you will, diagnose what the patient's desire for involvement might be. So again, a little bit of a complement to that last part. And this is called the control preference scale. And the idea here is that the intervention is to take this card, which has these 5 pictures, and each picture describes a point on a continuum from I prefer to make the final decision about which treatment I receive to I prefer to leave all decisions regarding my treatment to my doctor. The middle ground is kind of a partnership model. And so basically patients can think about where they think they lie on this continuum. And that can be very valuable for the physician to know at the beginning of the encounter, where they might be and what is their preferred style. Again, not every patient wants to be as actively involved as the others. Another approach has been decision coaching. Again, I made brief reference to this, but this is a notion where you actually identify a role in the practice environment for someone other than the physician who actually is going to spend a little time with the patient, helping them to become a more activated, engaged patient. And it sort of teases out the clinician's role to diagnose and make recommendations for treatment based on experience and clinical judgment, the patient's role around their values and preferences, and the decision coach's role is to assess decisional needs, provide decision support, and help basically get the person ready to engage in that decision-making process. This chart shows a variety of studies. Again, this is from another systematic review of decision coaching. And as you can see, in almost all of these except this one, the individual doing the coaching is not a physician. In fact, one of the things that we're seeing is increasing use of non-clinicians at all. So for example, pre-med students at one center are being employed as decision coaches. It's actually a wonderful experience for them, and it adds value to the environment. And you can see the kinds of things that they do. It's providing information, clarifying values, building skills, etc. So again, decision coaching is another promising practice that we're seeing in the patient activation area. So patient activation interventions, exploring patients' decision-making style, and decision coaching are 3 promising practices around activating the patient. How about informing the patient? Well, I already mentioned decision aids, just to say that there's a huge number of decision aids out there. Most of them are good, not all of them. These are booklets and DVDs that come from the Informed Decision Making Foundation, which are very well done. They're evidence-based. They have a standard high production value. There are experts who are developing more paper-based tools. This is a so-called option grid. The option grid takes 2 options. This is having a PSA test versus not having a PSA test, and kind of walks through very concise statements and very readable language around commonly asked questions. There's a wide variety of web-based tools. This is actually the Agency for Healthcare Research and Quality, a web-based tool on osteoporosis. So a patient could go through a very, at their leisure, web-based tool to support their learning about the options for osteoporosis treatment. So these are, again, each of these has in common, the high-quality ones, that they provide information that's evidence-based. They go through some activity to help clarify what the patient values in terms of outcomes, benefits versus harms, and provide some support to get them ready for the interaction with the clinician. This is a list of the topics from the 115 randomized trials, just to give you a flavor. There's a huge number of these decision aids across a wide swath of decisions. Atrial fib anticoagulation. I was talking about that yesterday with the house staff at St. Vincent, how that's gotten to be a pretty challenging conversation just with all the complexity. Wouldn't it be nice if the patient could get some baseline information before that to save a little time? It actually is quite effective. Screening conversations. some of the decisions in obstetrics. So there's a wide variety of these tools. Increasingly also as another tool is actually trying to develop better ways to communicate to patients about risk. So the classic thing is we start saying, well, the risk of this is 40%, or it could be 20%. And people oftentimes don't have the same facility with numbers that we do, and those numbers may not have the same meaning. So risk communication experts have found other ways to communicate numeric risk, such as the following. So the use of these sort of stick figures helps to convey visually a percent of risk. This actually refers to the likelihood that after a screening mammogram, a woman might get a callback. The callback saying the screening mammogram is abnormal and she needs to have a diagnostic mammogram. And if you say the chance of that is 60%, versus if you show this figure, the understanding, the comprehension from the typical patient is much greater. Similarly, you can do the same thing about even after the diagnostic, how many will need a biopsy, and so forth. So there's a lot of these tools that are being developed as part of decision aids to try to increase the understanding of the quantitative aspects of decisions. So mostly with informing the patient, what's been the greatest development, the most promising, is the use of high-quality decision aids, but certainly trying to pay attention to health literacy and numeracy considerations and appropriate risk communication strategies. Finally, with regard to the patient-centered clinician, how to help us to do a better job at engaging patients when they are activated and informed. I would point out that this has been an area of my own interest, and one of our early studies we actually looked at how good of a job we as clinicians are doing, particularly in the outpatient setting, involving patients in shared decision making. So this is a study we did in the late 90s. We had the opportunity to analyze over 3,000 medical decisions from 1,100 primary care office visits. What we had done is actually audio tape each of those office visits with the permission of the patient and the physician. And then we had coders listening to these audio tapes to look at the degree to which physicians engaged patients in shared decision making, either for very straightforward decisions like routine lab tests, for new medications, or for surgery or procedures. And what we found was that it wasn't so good. It wasn't so good. Overall, only 9% of those 1,100 visits, those 3,400 medical decisions, did the physicians meet the standard for shared decision making. So this really underscored the notion that we aren't, and again, as an educator, I've been thinking about this mostly as how do we better train medical students, house staff to understand the foundations of shared decision making and to learn the skills involved and to be able to be prepared to meet the patient once they're activated and informed. There's a wide variety of resources. One I'd point you to is this is a web-based resource called DocCom. It's produced jointly by the American Academy for Communication and Healthcare and Drexel College of Medicine. It basically has chapters on different communication topics, not just shared decision making, but the difficult patient, the behavioral counseling for substance abuse, a whole wide range of things. And it actually shows videos demonstrating the kinds of techniques that have been found to be effective. So it's a wonderful tool. That same organization also sponsors training, national training, but also regional training. One of the things I'm seeing is that a lot of healthcare systems are working with organizations like this to bring in, train the trainer and training their medical staff, their house staff, to be better able to engage in high-quality shared decision-making. I've also found it very valuable to try to help clinicians create sort of some time-efficient approaches, because we all recognize, and I'm sure you're thinking about this, that one of the big barriers to shared decision-making is time, particularly in the primary care setting where office visits are short. How do we do all this? And one way is actually to come up with some time-efficient practice sort of ways of conveying the concepts of shared decision-making. So statements like, I'd like us to decide this together. How do you like to make decisions? I've covered a lot just to make sure when I was clear. Tell me what you heard me say as a way of exploring the patient's understanding. Some people like to go with treatment A, others like to go with treatment B. Again, trying to find time-efficient ways to get to the gist of the patient's values and preferences. And then things like this might feel like a big decision. Who else would you like to help? These are some of the things that have come from our many conversations with practicing clinicians, those who have found time-efficient ways to say things. This is just a partial list. There are a variety of decision support tools that health systems have put in place to support clinicians doing this work. One system, the Palo Alto Medical Foundation, has employed shared decision-making navigators to help patients and help get them from the clinician's office to access a library of decision aids and other decision support tools. I mentioned the pre-meds. This breast cancer center, what they've done to help the clinician is when a woman has a positive biopsy and is referred to the breast center for her first visit, they contact her about her appointment time, and they also send her a decision aid. Then the health coach calls her to say, did you get the decision aid? Have you looked at it? What questions do you have? Let's talk about what's going to happen at your visit, and gets her prepared. So when she comes to the visit, she hasn't decided anything, but her level of understanding what the options are is much higher than it had been previously. So it's really helping the clinicians to sort of get started on that conversation at a much different place. Some health systems, group health, Mass General, and the Partners system has actually embedded decision aids in their electronic medical record. So when you make a referral, for example, to orthopedics for consideration of a hip or knee replacement, you can also click a box and the system will send a decision aid to the patient. So again, it's helping you to promote the distribution of shared decision making by putting it in the workflow, and it's also helping the specialist by having the patient come in a little much more better prepared to engage in shared decision making. So we've talked about activating the patient, decision coaching, exploring decision-making style, the patient activation interventions, the waiting room, the ask 3 questions, the importance of recognizing and accommodating health literacy and numeracy, but using evidence-based decision aids and good risk communication strategies, trying to find time-efficient models for us and those of us in busy practice who want to do shared decision-making, but there's only a finite amount of time. But also using communication training to be able to adopt some of those promising practices, and using these decision support tools that can bake some of this in to the workflow so it's not so difficult to do. So to me, these are some of the promising and I think very practical approaches to promoting shared decision making. And so I'd say that I hope that in this talk you have a better sense of what we mean by shared decision making patient engagement. You can see the emerging rationale through empirical evidence, obviously the ethical foundation and the policy agenda that's driving this, and hopefully there are a few of these promising and again I think very practical approaches that can help you and your colleagues to promote shared decision making and patient engagement. I appreciate your kind attention this morning, and I'd be happy to entertain your questions and comments. Please.
Would you comment on vaccination acceptance in pediatric practices? In my clinic, despite decision aids, I had some partners that dismissed patients from their care if they wouldn't go along with the recommended.
I'll just repeat the question. The question was about how do vaccination practices sort of fit into this model, and I'll make a couple of comments. I think it's a very, very important subtlety. So. Vaccinations, and again, I'll just say, I'll give you my opinion. You feel free to differ, but my opinion is that vaccinations are given for 2 reasons. One, for the patient, and the other is for the public. And we recognize that public health interventions rely greatly on the entire public being, accepting that intervention. So, as such, the autonomy for the individual in a public health intervention is qualitatively different than the autonomy for a patient where the intervention is solely for them. So if I decline to have, hip surgery, it's not a public health intervention, but if I decline to get vaccinations and I may suffer, but I also may, the public may suffer as a result of that. So it's not always clear that shared decision-making is the right tool for vaccinations. Now, I realize that in the modern era, it might sound a little, provocative, but I mean, I think that's just sort of the one way of viewing it. That said, I think there have been attempts to use similar approaches, that is, trying to use decision aids to help parents understand the rationale for vaccination outside of and put the basically zero risk into some context that versus the public health benefit. I don't know if that answers your question, but I think that as individual, I guess the other thing you asked was about, I don't believe that it's appropriate for physicians to use the threat of dismissing or firing a patient to get them to go along with their recommendations. I'll just say that as a statement. Certainly it's frustrating if patients won't go along with our recommendations, particularly when we're making them as really an arm of public health intervention. And we should pull out all the stops for persuasion and lobbying and advocacy, but it becomes potentially problematic to use the threat of discharging a patient as a tool, because that borders on being coercive. But again, that's just my view. Please.
So when you talk about shared decision, part of the problem I see is that, so I take care of asthma patients, there isn't so much a lack of information, it's that there's lots of information. So they walk in the door with their internet booklet, their insurance company has sent them things that said this is what you should do, they have a family bias, they see it on television, direct marketing, how do you, as a physician,
I think it's a great question. Yeah, so the question is, sometimes the problem isn't lack of information, it's too much information, and I would add to that to say information of different quality. Quality in the sense of how much is it tethered to an evidence base, and how much is it actually helping to drive a decision that's right for that patient versus just to drive, purchasing of more higher cost pharmaceuticals, for example. And I think that's actually where the move that's happening in Washington State is going to be potentially very important, because essentially the elevating high quality decision aids as qualitatively different from all the other sort of patient education stuff that's out there, ranging from websites, which some are great and some are terrible, to the promotional stuff from pharma, and having some standards that actually draw a bright line between the stuff that's high quality and the rest, could be actually very beneficial in that regard. But I think it's a big challenge, particularly for in areas where utilization is driven a lot by pharmaceutical promotion and disease advocacy groups and things of that nature. Yeah. Please.
That was very nice, thank you. And I'll apologize if this was on your slides and my eyes just couldn't read the fine print. So I see the value for decision-making, shared decision-making, for things like screening, mammograms, PSAs, and so forth. But what about our patients who are so vexed that are really harming themselves with narcotic abuse, tobacco abuse, etc.? In that fine print, was there any data showing an impact on their subsequent behavior?
Well, so again, I would say that in the broad area of patient-physician communication, shared decision-making is largely about which of our recommendations for an intervention. It has some, I think, relationship to the trying to change health behaviors, whether it's substance use or smoking or other kinds of unhealthy behaviors, and so it has a lot of overlap with the behavior change kind of domain. But behavior change modalities that are proven to be effective that would be kind of another talk. That said, I think there is a role for providing accurate information to patients about the impact of those health behaviors, but it's certainly not sufficient. So one particular health behavior change model suggests that to drive health behaviors, you have to change the belief about the behavior, you have to change the norms about the behavior, and you have to change the fundamental individual's self-efficacy, their sense of actually believing that they can change. Shared decision-making largely would focus on the informational piece, but certainly in any kind of behavior change situation, you would have to also probe, just like when you talk to people who are expressing readiness to quit smoking. You know, what are they triggers for their smoking when they go out to play cards with their friends, or whatever. You have to actually start to have them understand the environmental forces and interactive forces. You have to assess their readiness and help them to get more confidence in being able to change. So shared decision making is not sufficient to promote health behavior change, but it'd be an important component. I don't know if that answers your question, but you're right, there was nothing on the slide. You didn't miss it. Your vision's just fine. Please.
Thank you for coming. It's a really interesting talk. And I came in late because of traffic and all that, but so maybe I missed it, but it looked like shared decision making and activating patients was helpful with the patients' perception of their ability to make decisions and interact, and also seemed to help with costs in terms of the outcomes. I missed, could you give us, I know it's a big area, so could you give us a few good examples of impacts on outcomes, clinical outcomes?
Yeah, so the question was just, I said something about patients' confidence improving from shared decision making and cost, but maybe you missed the part about outcomes. So it's a huge area. So I would say that I'll give you a couple examples. Shared decision making in diabetes care, improving adherence, leading to better A1C control. Same thing in type 2 diabetes, same thing in depression. And largely in the medication realm, it's largely through improved adherence as a pathway to improved outcomes. And that, for me, it's always been very kind of aligns with experience that we think about the people who don't take their medications. Oftentimes it's because, I always have this image of a patient going home and I was practicing the VA for a long time, so the veteran they were very, many veterans were very passive and say, well, would you like to, try this medication? I think it would help. What are your thoughts? Whatever you say, doc. So I always imagine them going home and saying to their spouse or their friend, so how'd the doctor visit go? Fine, yeah, it was great. What happened? Yeah, he gave me these what's it for? So, and then, they're not sure what it's for. They take it and maybe they, start getting a little, nausea or whatever. They stop taking it. And everybody's experienced that, right? So the idea of actually, making sure the person has a working knowledge, again, not all knowledge, and again, that's another piece of sometimes too much knowledge, but also the notion that when they decide to take that medication, it's not just me giving you the medication, it's us deciding that you should take this medication. And that adherence has been huge across a wide variety. So that's probably the best. Even in the cost data, the one wrinkle that I didn't share is that in some of the joint replacement literature, what they're finding is that people who have joint replacements after shared decision making, people come in thinking, I wonder if I should have a joint replacement, do a decision aid, meet with the physician. Some of them figure out that it sounds like too much trouble, they don't want to bother. The ones that stay in and keep on that pathway actually have better functional outcomes. Now, why? It could be that it's tweaking the selection criteria, though largely the orthopedic surgeons are doing that based on clinical radiographic grounds. But it's also because they're going into it believing that it's the right thing for them. That attitude probably does translate into better recovery, et cetera, et cetera. So there's some outcome differences there as well. Yeah. Please.
I want to know if when you're measuring that picture of the 5 things, either I want to have decision making versus. Is there any measurement of the trust of that clinician ahead of time or the length of time they've been with the patient?
That's a great question, and I think what you're suggesting is that where a person might put themselves on that spectrum would depend on a lot of things. And I'll give two answers to that. For any individual person, where they place themselves on that spectrum does depend on the context. If it's a routine ambulatory kind of long-term, like should I take this statin or keep trying lifestyle control, that's one thing. if they're in the emergency room and they've got, right lower quadrant pain, they, think they've got acute appendicitis, most people are going to be on the, you just tell me if I need. So it does vary per person, context, situation. It does depend a lot on the relationship and the degree to which they're, certainly as patients begin to develop a long-term relationship with a primary care physician or another physician, they may actually extend more deference to that physician, which actually may be okay, may be completely in keeping with who they are. And also we're finding some interesting demographic differences as you look at this in terms of, for example, patients who are younger tend to be a little bit more on the control end. Patients who are older tend to be a little bit more on the passive end. Why that is, there's all kinds of reasons. I'm sure we're all speculating the same set of reasons. People who have higher education tend to be more on the control end. People with lower education more, and there's similar kinds of demographic trends that you see. So I think for me, I sort of take all that and think it's not so much that we should expect every patient to be at the same point on that continuum. It's really trying to help find the spot where they are and offer them the possibility they could be on a different spot if they'd like. So for example, I think a lot of times patients who don't have high educational attainment come to see a physician, and we've got, more, as my mother liked to say, more degrees than a thermometer, and it can be very intimidating. And so if they actually might like a different role, but they can't even imagine going there to even ask me a question. So if I can create an environment or use some of these approaches to actually make it a little bit more possible to even just ask some questions, I've probably helped that person to be closer to where they actually would like to be for who they are than maybe what they're accustomed to being, if that makes sense. I saw a hand over here, please.
Yeah. Continuing on, I think, from that question and more from a patient perspective, my experience with myself and families has often been with physicians that want to give you all the options and lots of information, but it's hard to push to get a recommendation to say, if you were me, what would you do?
Thank you for that question, because that's a we didn't really talk about that. The question is, what about the physician who is going so far into shared decision making that it starts to feel like, I'm going to paraphrase, it starts to feel like a menu, like you're in a restaurant. We have chicken, steak, fish, which would you like? And again, even in a restaurant, sometimes we might say, well, what's the best? What do you recommend? So I think this is a very important point. What shared decision making is not is for us as physicians to abdicate our responsibility to make our best professional recommendation, right? And I think sometimes shared decision making can get pushed to where it feels more like consumer choice, and that's not what this is about. Now there are some out there who misconstrue shared decision making as being about patient choice, and certainly patients should have choices, but the choices are driven by our assessment of the problem and our best judgment about what are a range of reasonable options. So if the options aren't reasonable, we shouldn't be discussing them. If we have less strong feelings about, well, your LDL is still pretty high, we've tried lifestyle, I really think we should start a statin. Let me try a few more months. Reasonable people can disagree, but a few more months, okay. You can imagine you're not as, but if it's, again, you're in the emergency department and you've got acute appendicitis, right? So and there's a whole range in between that. So I think our job as physicians is to invite the patient into shared decision making to the extent appropriate for the context, but always be sure that it's very clear to them that here are a range of reasonable options, and based on what I know about you and your situation and my experience, I'd recommend this, but it's very important that we decide this together, right? So it's very clear what my recommendation is, but it's also clear that I still respect that they may want to go a different direction. And if they do, and I feel like it's okay, 3 more months of lifestyle, maybe you're going to join Weight Watchers or you're going to start running or whatever, let's give it a try. And then actually what I found, and others can comment on this, is that when 3 months comes by and the LDL is still up, then it's like, well, we gave that a try, okay, fine. Then they're much more ready to actually start the statin, adhere to it, and to derive the benefits from it. So, but I think it's a very, very important point.
All right, any
we're out of time, so further questions can be up here.
Thank you very much.
That's great.
Thank you. Yeah, nice to meet you.
Good trip back.
Appreciate it.
Back right now, or?
Well, I'm going to